Hi, so we're back and we're going to talk about our intubation and induction agents for anesthesia. So when we're talking about intubation, we want to make sure that we are intubating our patients in a comfortable position. We also want to always maintain their body temperature. So once we pre-med our animals, it is really important to actually start maintaining their body temperature right away. So they lose their body temperature starting after we give them pre-medication. That actually decreases their blood pressure, which then their thermodynamics change quite a bit. So starting to heat them right away is going to help them maintain their body temperature throughout their anesthetic procedure. Rather than trying to catch up throughout the procedure, let's try to maintain it throughout. Lubricating their eyes, you can start lubricating their eyes even when they get pre-medded, or you can do it when they're being intubated, or even just after they're induced. But you should be lubricating their eyes every 90 minutes that they are under anesthesia and waking up, just because they're not blinking quite as much, and we don't want to cause any type of trauma to their eyes during this procedure. Pre-oxygenating them is really important. So pre-oxygenating them for at least 3 to 6 minutes prior to any type of procedure is great. It actually saturates the hemoglobin on their blood so that we can oxygenate all the tissue just in case of any type of emergency. An ET tube obviously should be placed in every single patient that is under anesthesia. So that even goes for any cat neuters and stuff like that. Granted, yes, cat neuters take not that long, but you never know in case of any type of emergency what's going to happen. It's harder to place an ET tube in an emergency than prior to. So if you can't place an ET tube right away, there's bead gels and stuff like that that are out there. Same thing, obviously, for cats and also for rabbits that you can utilize. So that can be and also a different type of method to use. So it is really important never to move a patient while they're connected to an anesthetic machine. Moving those tubes and twisting and turning them can tear trachea. Even the slightest movement could twist it enough down in that trachea to create trauma in there. We don't want to do that, obviously. So I'm sorry, bolus induction. So something kind of messed up here. When we talk about bolusing induction methods, bolus induction is when we give any type of medication and we give that medication all at once. So there's certain types of medications that we do give that way. So we're talking about like ketamine and Valium. We give that as a bolus. We give all of that medication at once, and that patient will go to sleep with all of that medication on board, and we give that amount dosed as a complete induction method rather than a titrated method of giving that medication. So just keep that in mind, like ketamine, Valium, ketamine, Midazolam, stuff like that, that we give as an induction method, or if you are doing like dexmedetomidine and stuff like that, it is a bolus induction. Titrated method is when we are talking about like propofol, etomidate, it's in a diazepam method, where we drop up a dose, and it could be a ranged dose that we're giving, and we give a small amount at a time and see how that animal is falling asleep. And if they fall asleep slowly at a time, or if we need to give more, then we give more. But we are slowly giving that over time to see if they will actually need less of that medication. So there's benefits, pros and cons to both. And so the pro, obviously, to bolus method is that we skip over that stage 2 phase quite faster than the titrated phase. Obviously, in any case, we would love to be able to skip stage 2 as much as possible. There's less likelihood of any kind of cardiac arrhythmias and stuff like that in that stage 2 phase. But also in the titrated phase, we can use a lot less drugs, And we would not have to necessarily have any type of apneic effect, hopefully, or just like an overdose of any medication. So there's definitely pros and cons to doing both. So that's kind of nice. Now, CRIs are interesting as well. I personally really like CRIs in certain cases. So, especially when we are, talking about animals that we are, uh, have that are compromised under anesthesia. So, you're talking to a person who worked emergency and critical care or oncology. So, I definitely never anesthetize. Spays and neuters. Very rarely. I guess I'd only did it when I was volunteering at spay and neuter clinics. So it was very weird for me to ever have a actual healthy animal that I was monitoring under anesthesia. So, and if I worked extra shifts, I was working in neurology or specialty surgery, so they were also not healthy animals. So CRIs were really fun to use because we didn't if we did a CRI, what we would do is we would use like a propofol CRI or a fentanyl CRI to help them under anesthesia, and then we could reduce the amount of inhalant gas that they were getting. And so, especially with propofol CRI, if you're thinking of it, this is metabolized by fat. And if you have an animal who has maybe liver compromised, that way we don't have to give as many medications that are going to have to be filtered by the liver, right? So it could be definitely helpful there. Now, keep in mind, propofol is such a great drug. We use it all the time for pretty much anything, right? Even as great for dogs who are not eating. You can give it as an appetite stimulant, which maybe some of you didn't know. Um, and um, and so the only problem with it, though, is that since it is metabolized by fat, it isn't very good for animals that have a history of pancreatitis or are currently experiencing pancreatitis. So you have to keep that in mind. Fentanyl CRIs, even morphine, ketamine, lidocaine CRIs are really helpful too when they're under anesthesia. So many times in specialty surgery, when we were doing orthopedics or any abdominal surgeries or pretty much any type of surgery, we used a pain CRI to help with anesthetic procedures. So we definitely utilized our medications to help during anesthetic procedures. So here is a constant rate infusion that we would use, and we use a lot of propofol CRIs too when we would have seizure animals that would come in and they were in status seizures for a long time. They were having seizures constantly over time, and we could not, no matter how much phenobarbitality you would give them, right, or diazepam you would give them, they were still having seizures. And sometimes even if you would give them diazepam CRI, they would still have breakthrough seizures. And so sometimes we would have to switch them over to a propofol CRI. And so I like to explain it even to owners that sometimes their brain needs a break. They've been having seizure after seizure after seizure. And so what we have to do is put them on a CRI of propofol and just let their brain rest, let it rest and reset, right? And so you give them a loading dose so they kind of just fall asleep, and then you just, let it rest and then slowly wake them up. And so these syringe pumps are just great. What you notice in the syringe pump here is that there is this really, really, really tiny extension set. It's super thin, right? And so these are really important when you have CRIs, is that you can get these micro extension sets that only hold 1.2 mLs is, I think, one of them, 1.2. And then there's another one you can get out there that holds 0.6 mLs. And that's really nice because then you don't have to get these long, your regular extension sets. And sometimes you need two, and it wastes so much of your drugs. We were using that for a really long time. And so when we use diazepam CRIs, we'd only keep out our diazepam for 4 hours because, as you know, it binds to plastic. So we would have to switch out our diazepam all the time. We were wasting diazepam like crazy because it would take, 4+ mLs to fill one extension set. So keep that in mind. You have these micro extension sets that were out there. Now, your constant rate infusions require more monitoring, of course, but you do have excellent control. You can play around with your rates a lot more, and you can give a lot of really good micro doses over extended period of time, which is really great. It does require obviously different equipment, meaning that you have to have a syringe pump and stuff, but the syringe pumps are not horribly expensive to get. All right, so when we talk about different induction methods, obviously there are a crazy amount of different methods we can give, obviously. I shouldn't say crazy amount of different ones we can give. We can give our intramuscular ones and our IV ones, and then we also have obviously our inhalant ones. I'm not going to talk about inhalant ones because it's pretty old school, and I try not to encourage inhalant induction anymore, like boxing down or masking down anymore, and we'll talk a little bit about that. But we have our intramuscular ones that are out there, which we do use still, and it's fine, obviously, for certain purposes. And then we have our intravenous ones. So intramuscular ones obviously have a delayed onset compared to IV ones. They do last a little bit longer too. So depending on what you're using it for, and everything, that's great as well, and where you are in the field. So obviously, if you are working in a small animal practice and you're going to have methods of hooking them up to the anesthetic machine and that kind of stuff, if you're using it for anesthesia versus sedation, that's going to change things. So if you're just sedating an animal really quick and then looking at it, IM might work better than IV. So it really just depends again on what you're looking to use induction for. Obviously, you're going to have a longer recovery with this method, so keep that in mind. We use ketamine, xylazine, tilazole, and dexmedetomidine. So these drugs obviously take a lot longer to kind of get through the system. Now, remember, we cannot give diazepam nor propofol IM. Alphaexalone we can give IM, so keep that in mind too. But diazepam is not water soluble, so we can't give that IM. We can give midazolam, so that's a better option for you. Propofol we can't give IM, so that's an IV only drug. And then we also have our induction methods of IV. So that is one of the ways that we can induce right away. And again, we want to make sure that we are avoiding that stage 2 as much as possible. So when we first start talking about some of the drugs that we really do use, especially like controlled drugs and stuff, we do have our barbiturates. So these drugs we don't typically use as induction drugs, but we have in the past. So I don't want to leave these guys out. So we have our barbiturates. They're highly lipid soluble, and we do have to, of course, be careful in our sighthounds. Now, the reason for that is because our sighthounds don't have a lot of fat on their body. So we can overdose these guys pretty easily. So we are very cautious with our sighthounds in this. So anything that those long noses, the fast runners, those guys. So barbiturates decrease any type of seizure risk. So this is why we use, phenobarbital in our animals with these. But they do sensitize our cardiac muscles and can cause arrhythmias. So we do want to monitor any type of ECGs when our animals are on any type of barbiturate. Okay. You can see VPCs, you can see ventricular bigamy, which is shown here. So just showing two separate different beats on our ECG strip. It decreases the risk of excitement on induction if we do give it. So basically our animals go down pretty quickly. And this is a reason why we really do try to titrate our barbiturates. So if you're ever doing phenobarbital loading, a huge reason why we want to titrate it is that these animals go down quickly. And so when we give our phenobarbital, we're giving about 4 injections over, a 2-hour period of time. If we gave phenobarbital loading super fast, like all at once, our animals would go down really fast, and they could essentially go down too quickly. So we want to really make sure that we're giving it slowly. So we give it over, at least a 2-hour phase. Sometimes we even have to back it off even longer if our animals are going down too quickly. And at that point, too, we bolused it to some animals at first. So, like our injection, we would give, that little tiny injection quickly and then flush it and whatever. They would still go down too quickly. So, we would have to sit there and bolus it over 10-15 minutes, or I'm sorry, titrate it over 10-15 minutes because they still were going down too quickly. So, you really do have to be careful with the barbiturates when you do give it as a phenobarbital loading type of thing. So you want to maintain their oxygenation and ventilation too. So if you're really worried that they might not be oxygenating okay, or they're going down too quickly with just phenobarbital loading, putting them just on flow by oxygen stuff too is important. But we do need a phenobarbital load these guys if they are having really bad seizures. Many times, if you're in a general practice and you don't have to phenobarbital load them with IV injection, we do it as a oral phenobarbital loading, which is fine. But when they are, as an active seizure candidate in an ICU, we do phenobarbital load them IV, and this is when we have to be pretty careful. And then, we can give obviously IV lidocaine if we're seeing any kind of ventricular bigamy or VPCs on their ECG. So phenobarbital is one of the bigger drugs that we utilize, and it's a Schedule 4 drug, and it is a long-acting barbiturate, so it is used every 8 to 12 hours. Pretty much we use it every 12 hours. Sometimes we see it used every 8 hours if needed. It is used for an anticonvulsant. It is kind of being phased out a little bit just because we're getting a little bit better with some of our anticonvulsants out there for some animals. And we're seeing some negative effects, obviously, with phenobarbital, just on liver, especially over time. So we are using like Keppra and potassium bromide, even though potassium bromide to me is kind of a pain in the butt. But it is used. Zonisamide is used quite a bit too. And so, we still use phenobarbital a ton, but there's a lot of other really good drugs out there that can be utilized, and I'm sure we'll come up with some more as well. So it can cause some changes in their behavior at first. So we just need to make sure that we're letting owners know that it takes about 3 weeks for this drug to really reach the effect in the body. And so, just give it time. A lot of owners just stop the medication because they don't like it, and don't let it reach that 3 weeks. One big thing is that it does weaken the bladder wall, and so animals too need to go to the bathroom a lot more often. So it's not based on like that they are eating and drinking necessarily more. It's just that they have to go to the bathroom more. So it's something that we need to let owners know about. And we already talked about phenobarbital loading. So pentobarbital is a Schedule 2 or 3 controlled substance. So Schedule 2 meaning that if it is just singly mentioned, then that would be Schedule 2. If it is combined with another agent, like pentobarbital, with whatever else, then it is a Schedule 3. So it just kind of depends. So euthanasia solution having, with something, in something else would be a Schedule 3. So this is really important to know because when you're talking with the DEA, and recording anything that is a Schedule 1 or 2 drug has to be recorded in a separate, if you're doing binders, has to be recorded in a separate binder than 3s, 4s, and 5s, right? So making sure that you put, if you have pentobarbital, you put that in your Schedule 1 and 2 binder. You won't have Schedule 1 drugs in your practice, but make sure you have your pentobarbital in that appropriate binder. Pentobarbital is a short-acting barbiturate, so it lasts 1 to 2 hour duration, but obviously it is pretty, it is a pretty fast-acting drug. So, and it's as a barbiturate, it doesn't have to be long acting to do what it's supposed to do, obviously. So that is why it's primarily used as a euthanasia agent at this point. And just how we described it to owners is that it is a overdose of an anesthetic agent. And so it is truly that. It's just an overdose of a very old anesthetic agent. Talking about old anesthetic agent, thiopental is not used in the United States anymore, but we still teach it for some reason. It's contraindicated in sighthounds, and it creates extravascular necrosis and sloughing. So if we did use it, we would have to place a catheter and have a great one stick placement so that we didn't, create any just horrible necrosis and sloughing. So now moving to drugs that we actually do use in practice, we'll talk about dissociative agents. So when we have dissociative agents in practice, dissociative agents have technically three different names that we call them. So they can be called dissociatives, NMDAs, or cyclohexamines. So you can see them all called that interchangeably. Some of them that you'll see in practice are ketamine and teletamine. The other dissociative agent that you won't see in practice is LSD. But LSD was the one that really became popular at first, and it had many good uses actually. And then I believe it was actually President Nixon who put like the big, basically took charge of stopping the use of LSD in psychology and psychiatric uses. So but there was a lot of great studies during that time about how LSD was making a lot of great changes for psychiatric patients. So obviously the misuse of it on the streets and stuff like that had a lot of different effect, but there was a lot of great use being done with LSD in practice. And so, but ketamine and toluidamine are obviously still used. And so LSD is a Schedule 1 drug, obviously. Ketamine and toluidamine are further down on the list. And so we'll talk a little bit about those guys. Ketamine has obviously some pros and cons of what how it's used in toluidamine as well. Some big things about the dissociative agents is that, like especially ketamine, it causes rigidity in animals too. And so we have to kind of counterbalance some of those cons. What also is really nice though about it is that it has that dissociative effect. So you see the hallucinations, there's a little bit of pain management in there too. So that is one of the nice things about it. So in that dissociative state, they have that hallucinations. There's a little bit of confusion, agitation, fear. They have increased sensitivity to light and sound. So we do have to be careful when they're starting to wake up that they go into a nice, quiet area that's hopefully low light. They may have an increased temperature with that, especially in cats we've seen. So keep that in mind. And then again, that muscle rigidity is there, and then decreased sensitivity to pain, which is the nice part. And then also they have a seizurogenic at therapeutic doses. So this is kind of an interesting thing too. So this also as in humans too, they have found even for like migraines as well, they're using ketamine to help with seizures and then also with migraines. So they have done like nasal sprays and stuff like that as well, which is kind of interesting. So this is something that I think we'll see maybe more and more is, will ketamine be helpful for animals and even people long term? It's not good for animals that have pre-existing cardiac disease. So you may see that, with in practice, like what protocols are we using for those cardiac pets? So this is important when we are talking about that we can't have a blanket protocol for every single pet that we see in practice. Everyone has to have an individualized anesthetic protocol because of different metabolic diseases and stuff like that. It does make the heart work harder, obviously, and you will have an increased heart rate, your increased cardiac output, increased blood pressure, increased intraocular pressure, and then they salivate a lot more too. So these guys are Schedule 3 controlled substances. Tilazol comes with, and I'll show you in a little bit, it comes with a benzodiazepine in it, but ketamine is all by itself. And ketamine and toluidamine can be administered IV, IMPO, and then you can do them as a CRI. We do see ketamine CRIs quite a bit. This can be good for fractious cats just because we can give it IM. And then Tilazol can be used in a syringe pull or dart guns. We see a lot in dart guns and wild animals and stuff like that. And there's a spray for fractious animals too. You can put it in their mouth and spray it, and then, that way they can be sedated that way, or just at least quieter. So how we give it as ketamine diazepam or ketamine midazolam too is that we combine it in a syringe and give it immediately. It's not necessarily recommended by the manufacturer, but this is what you'll see mainly in the hospital. It cannot be mixed and stored. It's dosed as a 50-50, and they do it at 1 ml per 20 pounds. So this is a super old school dosing aspect of things. When you see it as poundage, that's an old school dose. Most times you'll see it as, you know, milligrams per kg. So there's minimal toxicity, cardiovascular toxicity with either agent. The muscle relaxation of the diazepam helps with any type of muscle rigidity, and you just have a smoother recovery with the diazepam on board. And then you just make sure you can't give it IM because of the diazepam, right? It's not water soluble. And so our next one is ketamine and xylazine. So this one you can give IM because both of these guys can be given IM, all right? The nice part about this is that xylazine is reversible. So with xylazine being reversible, you have to remember which agent reverses it, right? So the way I remember it is that there's two alpha 2s, and so the alpha 2s are dexmedetomidine and xylazine. So dexmedetomidine is in the beginning of the alphabet and xylazine is at the end of the alphabet. And so dexmedetomidine being the beginning of the alphabet, atipamezole is the beginning of the alphabet. So those guys go together. And xylazine is at the end of the alphabet, and yohimbine is at the end of the alphabet. So those guys go together. So xylazine and yohimbine. Xylazine is the one that makes you fall asleep. So it is the agonist. And the antagonist is the little kid, right, who makes you wake up, like comes in the room and is annoying and makes you wake up. So yohimbine wakes you up. So when I talk about tilazole or tiletamine, it is in a commercial available preparation, and it comes with the benzo on it. So that is zolazepam. So again, it reduces the risk of seizures. It has that muscle relaxation. It's great for aggressive or dangerous animals like this African wild dog. And it's water soluble. So it also has a PO administration like tilazole meatballs as well. So that's my dissociative agents for you. So our hallucinant, our hypnotics, our hypnotics that we have, so our Propofol. So Propofol is it's not a controlled substance. A lot of people put it in their controlled box, but it's not a controlled substance. So they just keep it there. But it is a milky white compound. This one, the blue one, is a 24-hour, or they say you can keep it for 24 hours, but it has a emulsion of glycerol and and egg in a soybean base. So it's just a medium for bacterial growth. So basically, it has to be discarded within 12 to 24 hours of opening it. So regardless of if you put it in, a refrigerator or not, the shelf life of it is very, very short. So it was so with this propofol, it was actually the first to be made, and we currently utilize this for cats for the majority of the time, or if you're utilizing this pretty quickly, you can still utilize this. and it is IV only. It can cause perivascular sloughing if you don't have a great placement of an IV catheter, so you just have to be really careful. And so we do, what's really great about Propofol is it has a rapid onset and a rapid recovery. You have to be careful, though, that it can cause profound apnea if given too quickly. It's a great choice for any patient that has seizures, or you're using this for an MRI, just for any animal that has potential brain issues at that given moment. We do recommend pre-oxygenating any patient, just to make sure, again, that we are going to really saturate any type of, saturate all of their hemoglobin, just in case there's any apnea during the time that they are being induced. Again, this is really contraindicated for any patient that has a history of pancreatitis, just because this is metabolized by fat, and we can give it as a CRI, so it's great. So then we created Propofol 28, which has a shelf life of 28 days, and it doesn't cause any kind of sloughing or necrosis of the if it's excavated out of the vein. And it's not really recommended for cats, just because of the alcohol base that makes the extended shelf life. Now, they have had some studies that show that, yes, we can give these to cats, as a one dose thing, but we can't go outside of the dosing range, just because cats can't metabolize that alcohol base. So it is okay. But if you have the blue stuff on your shelf and you can use it, like, go ahead and use that first. So just be careful with it, and just not like OD them on Propofol 28. So etomidate is kind of a fun drug if you have it, and whatnot, especially if you have, cats that come in that are blocked. It's really nice to be able to use. It's not a controlled substance. A lot of times when I've used it, they've left it in the crash cart, because we use it a lot for blocked cats that are need to go under anesthesia to be unblocked, and it's been on an emergency. So it is high lipid solubility, and we titrate it to effect. So usually we would combine it with like a diazepam or midazolam, and we reserve it for cardiac patients. And so we don't really use it that much because it's really expensive. And then once we open the vial, it has to be thrown away. So they do come in really little vials, so that's a nice part. And it increases the seizure threshold, so it makes seizures less likely. And we use it multimodal, so that's the nice part. And so, yeah, so it just kind of counterbalances everything. And it can cause phlebitis, so it's really important that you flush your IV catheter really well afterwards, or even change those IV catheters even afterwards too, if you can't flush it or can't make sure that it's flushed really well afterwards. Giving rapid injection of it can cause hemolysis in cats, and especially since we use it a lot in cats, just make sure you give it slowly. And a lot of times we see vomiting post-operatively with it. Now, it's hard to say, is this vomiting post-operatively that I saw because of etomidate, or the fact that we had to do a cysto when they first came in, because they were blocked. A lot of times when you do cystocentesis on these guys, there's some indication that doing cystocentesis on these blocked cats can make them vomit as well, which is something really interesting too. So yeah, who knows? So Alphaexalone is also another drug that was approved in the US in 2014. And I feel really old because I remember all of this. So I remember all, even when Deramax came out and everything. So it's kind of weird. So it was reformulated and labeled for dogs and cats. It's extra label usage for IM in cats too, as long as you go yeah, so it's a deep sedative, light anesthetic. And so IV induction slowly to effect over 20 to 30 seconds. And then usually they're recumbent within 60 seconds after you start that injection. So you're able to intubate pretty much in, a couple minutes. And then it doesn't have a storage issue like propofol. So it's kind of nice that you can keep it for a while. A lot of people have been pretty much using it over propofol, but it is more expensive. So that's the other thing. This is controlled, so you have to be logging it and everything. So those are the main drugs that we have kind of been using, and we'll go over more from there. But inhalants and induction methods that, I personally don't use and is not recommended. Our anesthesia nerds don't recommend either, but these are just masking in chamber. This gives you a longer stage 2, and you don't have a protected airway. So there are some that obviously we can't avoid. So like, turtles and stuff that, we just have to do, but it's a gradual process. There's a lot of WAGs, what's called waste anesthetic gases. But like I said, no protected airway and a large excitement phase. And so endotracheal intubation, so we have to have that secure airway. It's just that primary requirement for safe anesthesia. And then, if we don't, they can have brain damage and even sometimes death. And then, if anesthesia just increases that risk of complications. So having that endotracheal tube without a question ensures that. So giving intermittent positive pressure ventilation. It's a forced delivery of gas. We call it bagging. If you have a lower respiratory rate, you can go ahead and give a breath. It prevents atelectasis, and then you can also change the anesthetic depth that way. So different endotracheal tubes that you have. So this is just kind of the anatomy of the tube itself. So you can measure the tube that way. You have like a soft tip there. As you can see there, there's the Murphy eye of our tube right there. There's a valve as well, so you know the pressure that you're making of the cuff. And we also have uncuffed tubes for smaller animals as well, but there's still a Murphy eye. We pretty much use the ones that have Murphy eyes. And so we have different type of material of tubes. So a lot of the ones that you'll see in practice are the vinyl plastic tubes, so the PVC tubes. It resists cracking. These are the ones that are supposed to be one-use only tubes, but a lot of practices just wash and reuse these tubes. It is recommended now but that we either discard these tubes, or if you have an ethylene oxide sterilizer, that you can actually wash these tubes and re-sterilize them. If you don't have an ethylene oxide tube, you can discard them and then get new tubes. They're only a couple dollars usually, and many practices will, you know, uh, many owners would happily pay for those on their line item. Or if you want to conserve the environment, there's other tubes you can get, silicone rubber tubes. These guys actually can be washed and then also autoclaved in your steam autoclave. So it may need to get a stylet to kind of stiffen up the tube when you're intubating, but they're really nice and conform to the trachea of each of your patients. So I definitely recommend that. So you also have a Mcgill tube, and this is, this is very similar to your Murphy tube, except for the fact it doesn't have a Murphy eye. So that's the only big difference. And then your Murphy tube has that Murphy eye. So just kind of make sure you remember that. The cold tube are for patients like exoticing, especially birds that have that straight end the end of it. It's for those patients that have complete tracheal rings, so they don't break the rings of the trachea. And then this is just kind of a rough guide of how to intubate. So I made this when I was finishing up school about 15 years ago. And I just like to say that, like, oh gosh, I think it was beagles are about a size 7. So then you kind of rough guessed everybody else. But truly, the way that we measure is nasal septum, but it's not always accurate. You know, the weight chart's not always accurate either. But you kind of just take your tubes and go one size above, one size under, you know, and just do your best. So, but this is what I made as like a training guide for everyone. And then we also want to measure length too. And we want to make sure we don't have too much dead space either. You know, we don't want too long of a tube. And then our intubation technique. So dogs, cats, small ruminants, swine, we can actually see, right? We can see the soft palate, the epiglottis, and the retinoid cartilage. So we want to make sure that we can see and visualize everything. In cattle, we're doing digital palpation. Horses, rabbits, and rats is blind, but in dogs and cats, we should be able to see, so to pull down the epiglottis. And then, you know, for induction and intubation, this is just the procedure. So in cats and brachiocephalic animals, we are going to secure that ET tube behind their head. And in large dogs, we're going to go over the top of the muzzle, making sure that if you're having a long procedure as well, especially over the muzzle, untie that tube, or I'm sorry, untie it and reposition so that you're not going to cause their muzzle to swell up either. And I'm talking about a long procedure being, you know, several hours, or if they're on a ventilator for a long period of time, not just, you know, 45 minutes. Don't worry about that. Confirming ET2 placement, so visualizing, correcting placement if you need to, palpating the neck to feel 1 tube versus 2 tubes, you should feel 1 tube. Feel for breaths if you see condensation, and then also watch the reservoir bag. That's a really good one. But the most accurate way is to actually monitor the ETCO2 monitor. So looking and making sure that you're seeing the respirations and seeing that the ETCO2 on there is actually accurate. So consequences of intubation. So obviously you're going to see, you know, laryngeal spasms with cats, and how do we counteract that? Potentially lidocaine could work. We don't want to create any type of trauma, obviously. So tracheal trauma can happen, and necrosis. So, you know, making sure that we don't overinflate those cups and stuff like that. Coughing could happen, so it's definitely something to let the owners know about. Esophageal intubation happens, so just being cautious and making sure we visualize. Endobronchial intubation, so making sure we don't go too far down into our trachea, and making sure we go to the thoracic inlet. Impaction and obstruction, so making sure that they are breathing appropriately, their SpO2 is okay, they are not having any gurgling sounds in their tube, and then the fire hazard, of course, making sure that you know, like, all right, your surroundings, and knowing that our patients hooked up to a bunch of gas, oxygen and stuff like that, and there's a lot of fire hazard around. And then chewing or biting. As I wake up, you know that your ET tube is in, and we need to remove that ET tube as soon as they start waking up and swallowing. So we just went over some alternatives. So the V-gel is really good for cats or for rabbits, of course, especially for intubation purposes where it might be difficult. This is really good for, you know, if you're doing shelter medicine and stuff too, where you might not have the means to be able to intubate them quickly. We went over coughing, all of that. So when is a good time to extubate? They must be swallowing at least a minimum of 2 times. These bulldogs and stuff, this is the first time they're actually able to breathe really well. So let them have their moment. So they do take a little bit longer. So be sure to, give them some extra time. Make sure to deflate the cuff, untie from the patient, and then gently remove and inspect the ET tube really well. If there's any blood, mucus, anything like that, double check and make sure that you don't want to culture it before you get rid of it. All right, so we will start with inhalants in just a moment, and I will talk to you guys soon.